Coming to question 26 of previous NEET PG, another hematology question. So question is about what's the diagnosis. So 43 years old female comes with anemia, 5.8 gram per cent. She has history of fibroid uterus with abnormal uterine bleeding. Further evaluation showed peripheral smear showed pencil cells, microcytic hypochromic picture, serum iron was 10, ferritin was 1, TIBC was 500. So don't get confused. Whenever in such big questions, focus on the last word, what's the diagnosis, and try to note down the clues. So it's a case of anemia, severe anemia in a female who has abnormal uterine bleeding, right? This itself will solve most of the things, right? Every word is important in a question. And from the reports, peripheral smear showed pencil cells. Remember, pencil cells is very, very typical of iron deficiency. Like you would have read, target cells are very specific for thalassemia. Bite cells, which occur in G6PD deficiency, or other diseases like thrombotic microangiopathies like HUS or TTP. Likewise, pencil cells occur in iron deficiency. So that is one straightforward clue. Usually they'll be giving the reference ranges here, but if you remember, iron will be normally more than 20 microgram per deciliter. 10 is low. Ferritin is only 1 nanogram per deciliter, which is very, very low. It has to be at least 10 nanograms per deciliter. So iron is low, ferritin is low. TIBC, if they are given the reference range, the normal reference range is up to 400 micrograms per deciliter. Here it is 500, so TIBC is increased. TIBC is nothing but the free transferrin. Okay, transferrin is a protein which transports iron. When iron is low, transferrin will be high automatically because there is not much of free transferrin which is not bound to iron. So low iron, high TIBC, low ferritin. There is another ratio called iron by iron binding capacity. That ratio is called as transferrin saturation. That is also low in iron deficiency. Okay, so even if you are not very well versed with this thing, please remember the clinical clue. There is a bleeding. There is an abnormal bleeding, right? So most probably iron is getting lost. So this usually will be iron deficiency anemia. Suppose they are giving you a clinical clue where there is no abnormal uterine bleeding. It's a young female without any comorbids, presents with such microcytic hypochromic anemia. You can think of other things. So a small discussion about microcytic hypochromic anemia. Again, this is a pathology plus medicine integrated question. There are 4 causes of microcytic hypochromic anemia. Remember with the mnemonic SITA. S for sideroblastic anemia. I for iron deficiency anemia. T is thalassemia. Anemia of chronic disease. Always in big questions, try to pick up even small clinical clues. Like sideroblastic anemia, sidero is iron. There will be always things of iron excess. Like ferritin will be high, iron will be high. And plus, one clinical manifestation of iron overload is there will be discoloration of skin. Right, the so-called bronze discoloration of skin. Iron deficiency anemia, just now we had discussed. Patient presents with some bleeding manifestation, reduced iron intake, and iron deficiency in children will cause reduced concentration. There will be abnormal food habits, pica. Okay. Worm infestation history may be given. Thalassemia is a hemolytic disorder, so it's also an autosomal recessive disorder, so there may be a family history, consanguinity history may be given. Okay. And there will be no comorbids like bleeding, and it will be younger age of onset. Please remember, thalassemia major is a hemolytic disorder. Thalassemia trait is the actual differential for microcytic hypochromic anemia. Okay, thalassemia major is a hemolytic disease. It presents with differently like hemolytic phases, etc. Anemia of chronic disease, they'll have some chronic disease like anemia of CKD. Now, what will be the hallmark in chronic disease? Ferritin being an inflammatory marker, ferritin will be high. Transferrin will be low. That is TIBC is low. Like it's the opposite of iron deficiency, right? So an iron deficiency anemia versus anemia of chronic disease. Iron is low. Ferritin is low. TIBC is high. Here it's the opposite. In anemia of chronic disease, iron is normal to high. Ferritin is actually high. Ferritin is an inflammatory marker. TIBC, transferrin is a negative inflammatory marker. It gets reduced. So TIBC will be low. So this is how you analyze this case. So this is clear. Patient is having anemia with a bleeding disorder. There is pencil cells, microcytic hypochromic anemia. So one among Sita. Iron is low. TIBC is high. Ferritin is low. So this is iron deficiency anemia. This is not anemia of chronic disease because no chronic disease is given. It's not sideroblastic anemia because ferritin is low. Thalassemia major is a totally different entity. It's a hemolytic anemia. Had the option been thalassemia trait, we could have thought about it, but thalassemia trait usually never produces severe anemia. It only produces mild anemia. So this is also not the option.